I'm really excited about this particular discussion. We're going to highlight two examples of randomized control trials of payment reforms implemented by the Center for Medicare Services, also known as CMS. As a lot of us know, just as a little bit of background, historically, healthcare payment in the US has been driven by a fee-for-service model in which payments to healthcare providers are tied to each service that a patient receives. Amid growing evidence of inefficiencies and poor health outcomes, from this particular model, there's been an emerging movement which is advancing new models of healthcare payment that instead links providers' reimbursements to the value of the services that they provide rather than the number, both to individual patients and to broader patient populations. So during this session, I'm really excited for the three panelists who will be joining me. We'll hear from them about, as I said, efforts to rigorously evaluate payment reform efforts, the policy implications of these findings, best practices for conducting future trials like these, and how their findings can work to change policy. So let me introduce our three speakers. So first, we'll be hearing from Professor Neil Mahoney. He's a professor of economics at Stanford University, and he'll be sharing research results from a recent randomized evaluation of bundled payments for hip and knee replacement for Medicare patients. After Neil, we'll be hearing from Dr. Darshik Sanghavi, who will discuss his work as the former director of preventive and population health at the Center for Medicare and Medicaid Innovation, also known as CMMI, and efforts to spearhead a CMS RCT on the Million Hearts Cardiovascular Disease Risk Reduction Model, which seeks to prevent 100 million heart attacks and strokes over a 5-year evaluation period. And joining Professor Mahoney and Dr. Sanghavi is Mark Miller. He's the Executive Vice President of Healthcare at the Arnold Foundation, who will contextualize these two randomized evaluations presented here today in this sort of larger policy conversation and how rigorous evaluations can inform efforts to improve healthcare delivery. So for our audience, if you would like to ask panelists a question during this discussion, please use the Q&A function. I think several of us have been doing that already, but just as a friendly reminder, we'll address them toward the end. So the way this is going to work is I'm going to have each of our speakers sort of share some opening framing remarks to sort of contextualize our conversation, and then I'll sort of jump back in and moderate our discussion. So with that, I'm going to hand things over to Neil to kick us off. Welcome, panelists, and thanks for being here.
Thank you, Hannah. Glad to be on the panel. So what I'm going to do is share some slides which will provide background for what I'll spend probably 5 to 7 minutes talking about. So I'm going to talk about sort of efforts by myself and a team of co-authors to learn from comprehensive care for joint replacement, or CJR, which was a RCT implemented by the federal government, by CMS. And I think when we first learned about, trying to advance the slide, when we first learned about this study, I think we were sort of pinching ourselves. We couldn't really believe that it was being implemented. And the reason why is I think all of the co-author team separately or jointly had experience running RCTs where randomization was conducted at the patient level. So, through hard work and persuasion, it's sometimes possible to convince like a hospital to randomize some program to some patients and not to others. But we were less optimistic that this was possible for payment reform, where the sort of unit of randomization had to be a doctor's group or a hospital system. How could you convince hundreds, thousands of hospitals to participate in RCT? Of course, the federal government is in a different position. And so, when we learned about this study, we really couldn't contain our enthusiasm. So what is CJR? So it's a mandatory participation nationwide randomized trial of bundled payments for hip and knee replacement. So as Hannah was saying, historically, Medicare, the federal government, pays hospitals, nursing homes, and doctors on a fee-for-service basis. So they pay them, for each claim they submit. And the promise of bundled payments is, rather than paying for each item, you make this one bundled payment. It provides incentives for the hospitals to not engage in wasteful utilization. There are also quality incentives, and so you can have lower costs and higher quality. But bundle payments had only been studied in non-randomized settings before CJR. So what did CJR do? Here you can see on the left, basically took cities or MSAs. Some were excluded because of participation in prior programs or because of small volume, but of the almost 200 eligible cities or MSAs, 75 were assigned to treatment, 121 were assigned to control. This, I can't emphasize enough how big this study was. Something like 1,600 hospitals, over 130,000 patient episodes per year in either treatment or control. So you can see on the map on the right, these MSAs are all across the country. So huge study. And if RCTs are the gold standard, then CJR was basically a gold mine for us. We are working on paper 3. The first paper that came out of CJR is just sort of a plain vanilla analysis of treatment and control. What I'm showing you here is basically the key table in that paper. So we hypothesized that CJR bundled payments would have the largest impacts on whether hospitals choose to discharge somebody to a nursing home or send them home, perhaps with home health care and other supports. And so that was our pre-specified outcome, was a fraction of patients discharged to institutional post-acute care, mainly nursing homes. And what we found is in response to the bundle payments, where hospitals are internalizing the costs of sending someone to a nursing home. So you send somebody for 20 days, $500 a day, right? That's $10,000, so pretty strong incentives to not send them to a nursing home if you don't need to. And we see a 3 percentage point reduction in the first year off a base of 33%. So about a 10% reduction in sending patients to nursing homes. There's a corresponding reduction in costs, no effects on quality, sort of consistent with the clinical literature that has been suggesting that sending people home after a hip and knee replacement actually might be good for their health because they get on their feet faster, and that's good for their rehabilitation. So paper 1. Paper 2 then, something that was really exciting to us, sort of this big question in healthcare is whether Medicare, because they're large, can they drive change in the entire healthcare system? Can they have positive spillovers onto private payers? That's really hard to study because if you look at the effect of a Medicare payment reform on private healthcare, if you see something, is that a spillover effect or is that a placebo check gone wrong? Right? Are there some unobserved trends happening elsewhere in the system? And so that's why you're finding something that looks like a spillover, but actually is telling you that your study isn't well specified. Well, with an RCT, that isn't an issue. So this is a paper we published in PNAS. Here's the main table. Again, we're focusing on this shared discharge to institutional post-acute care. On the left, I'm showing you, these were the intended effects on traditional Medicare. And it's, again, the same sort of 3 percentage point reduction. On the right, now I'm showing you Medicare Advantage. So these are private health insurance plans for the elderly, not targeted by the program. You see an effect of the same direction and basically the exact same magnitude. So this is consistent with, hospitals are changing their discharge systems, bringing in discharge nurses, installing software which allows them to better classify patients. And when they do that for traditional Medicare, it spills over onto Medicare Advantage. So Medicare is leading change through payment reform, sort of across the healthcare system. Final paper not published. We are deep in the sort of trenches of the revision process right now. But something that happened with CJR, basically 2 years in, Trump is elected and his sort of officials in charge of the program want to scale it back. What do? For basically half of treatment group hospitals, they say, the program isn't mandatory anymore. You can choose to stay in or you can choose to leave. For the other half of the treatment group hospitals, the program is still mandatory. So we were originally hugely frustrated, then realized there was an opportunity to turn sort of lemons into lemonade. And so in particular, what this allows us to do is study who are the types of hospitals that choose to stay in a program, to be in a program when it's voluntary. And what's really cool about this environment is for those hospitals that choose to stay in or choose to leave, we actually see them under the RCT for the first 2 years. And so we can ask, are the hospitals that voluntarily select into bundled payment, are they the hospitals that have big treatment effects? So these are exactly the hospitals where you're getting the biggest social benefits from being in the program, or are the hospitals that choose to stay in the program sort of the hospitals that are adversely selected in that they're the hospitals that basically got big payments from being in bundled payments without changing their behavior because the target price was wrong for them or because they had particularly low costs. So, I think the bottom line, if you didn't follow all the details, is this was I think, incredibly valuable RCT, not only for studying the impact of bundled payments, and there I'd summarize the effects as sort of a single rather than a home run, but really solid evidence, but it had all these other unintended benefits. Because the program was huge, we could study spillovers. Because the program has been changed, we can study selection to the program. And so I think just further evidence that these large RCTs have benefits which might even not be predictable on the onset. So longer than 7 minutes, but I will now pass the mic to the other panelists to take things from here.
Thanks, Neil. Go ahead, Darshik, whenever you're ready.
All right. Hey, it's a pleasure to be joining you all today. I'm Darshak, talking to you from my home office in Boston. So I wanted to talk a little bit, building on what Neil said, a little bit about one of the largest randomized trials that we worked on when I was at CMMI, and then also use this as an opportunity to discuss something that's adjacent to this discussion on data and randomized trials, which is how do these experiments then make the jump to policy, and a little bit about both the science, but also some of the realities of how that actually occurs. Because I think many of us are in this work, not just for the theoretical joy of doing these evaluations to get better data, but because we're interested in actually making the healthcare system better. And for that, I'll just sort of talk through a couple of the lessons I had. But I want to talk first about the Million Hearts model. So I was at CMMI, I was the first permanent director of prevention and population health there. And as you're probably all aware, CMMI had the regulatory ability granted from the ACA to waive a number of Medicare and Medicaid regulations in the service of doing broader experiments. And then through statute, what was really the superpower of CMMI was that if the projects were both improving clinical quality as determined by the chief medical officer of Medicare, as well as having either neutral or beneficial effects on cost as determined by the CMS actuary, then those experiments could actually, you could just make those regulatory changes without going through any congressional approval. So the idea was to have an independent strategy to make healthcare better. So the problem that, one of the problems I was given was to say, how do we better invest in long-term prevention? Since you may not see benefits for a long period of time, how do you fit that into a value-based framework? So what we came up with was this thing called the Million Hearts model. So as many of you are aware, if you're over the age of 40, if you've ever seen your doctor, they're supposed to tell you your 10-year risk of heart attack or stroke through a little calculator. It's actually very simple. It's when I talk about this, I ask in the audience, if you're over 40, have you actually had your 10-year risk check? And it's surprising how few people have had that done. That's actually the standard of care according to the American Heart Association. So we did something very simple, which is, look, calculate your risk over time. We're going to take a doctor and have everybody in Medicare fee-for-service that doctor takes care of. We're going to calculate the risk and average that risk together. And then that doctor, if they can lower that aggregate risk, that population health, then you get paid a certain extra amount for that. So the idea was essentially to securitize a future outcome in sort of today's dollars. That might be the kind of the dorky way to put it, but the simple concept was we just want people to calculate your 10-year risk, have a conversation with their patients about what the best thing to do is, stop smoking, or is it blood pressure control, cholesterol, aspirin, and then make changes. So well, how do we set that up? So actually, I think there's a really nice blog post that Amy and I wrote together where we told a little bit of the background of how this came about. I'm really grateful to some of the thinking at JPAL and others to make this randomized. But we created a project which launched in 2015 where we randomized practices that volunteered for this into either getting the payment and access to the calculator versus routine care. It was randomized at the practice level. Ultimately, we wanted to shoot for 3.3 million Medicare fee-for-service beneficiaries. And this is sort of, I just like to say, we were really successful and we're very proud of the work we did in collaboration with a number of our partners, including AHA, ACC, the American Academy of Family Physicians. We worked with CDC, and then a number of other approaches to try and enroll very, very broadly. This is different than the model Neil talked about, where the randomized, the comprehensive joint replacement model, that was actually imposed by CMI to some extent. This was a voluntary model. And Brad Smith actually has a really nice piece in the New England Journal where he talks about the pros and cons of all those approaches. Anyway, that was the idea. And you can see that we had a good deep, that those are little dots are where all the practices are located. And I'm just going to show you a little bit about what are the results that have been shown so far. By the way, this is the app, if you've ever done it, that just kind of gives you your 10-year risk. Again, super simple. All this stuff is public, by the way. It just kind of gives you your risk. If you actually, for fun, if you want to, you can go on after this talk and look for it yourselves. I encourage you all to do this. Anyway, here's so these results just came out earlier this year. So this is the work, I believe this is RTI that looked at this. And what's really fascinating about this is we actually, by the way, just to look at the highest risk, looked at people who had an average 10-year risk over 30%. That's in the light blue at the bottom. And you can see after 12 months of enrollment, you can look at what happened to those individuals over time. So incredibly, their 10-year risk dramatically shifted downward over that period of time in the model. Now, what's interesting is I want to mention, by the way, this is just the high risk enrollees. At the top now, you can look at the impact of what changed in the comparison group versus the group that was randomized. And you can see that the percentage of respondents that actually had an intervention that was put together dramatically improved. And there, interestingly, was an actual reduction in all-cause mortality over that time as well, of relative reduction of about 8%. So this just goes to show the power of this approach. And now the question is, we know this, right? Imagine an intervention. It's a simple payment model. It's like super cheap. Like, do we know enough to make this Medicare policy? Is this strong enough data? Like, it looks pretty good. I'm just going to talk a little bit for a couple minutes about how that decision-making process works, because I think there's one step here that we were able to get really high quality data. Now, what does it look like to actually become policy? If we can actually reduce cardiovascular mortality, all-cause mortality by 8% in this population group, that seems like something that's really, really good. We should generalize that, right? So apropos of that, I'm going to give two examples of, or at least a key example of how we did this in the past. I'm referring to the, I'm going to go to the diabetes prevention program. So this is another project that my team had been responsible for. So as many of you are aware, this is data from the CDC funded trial in the early 2000s. Look at the impact of metformin, which is a medication, versus lifestyle intervention, the diabetes prevention program, which is roughly a 12 to 16 week program of exercise and social engagement. And looking at individuals who have pre-diabetes or impaired glucose tolerance and the risk of progression to type 2 diabetes. Now look at this over time, you can see, remember this intervention is just for like 2 to 3 months, but 10-year follow-up of this randomized trial from the CDC demonstrated, look at that lifestyle intervention, look at that impact on type 2 diabetes. Imagine if this was a drug, right? Like just how like this would have been paid for and so forth, but it never went anywhere. And that was in 2003. So our team actually funded a pilot program to actually, because if you see them on my dollars, we had the YMCA deliver the DPP in community-based settings. And we actually reproduced this impact. It was a 12-month trial. And then we looked at the total cost of care. This is again, another evaluation that now, remember, this is non-randomized. So I'm showing, we talked about the importance of randomized evaluation in the Million Hearts model. This was non-randomized. We just paid random community centers to do this. And we created a comparison group. Look at this, in quarters 1 through 8 here, immediately in the first quarter after the DPP started, it looked like the per member cost was $500 per month cheaper. And so over time, we said that our actuaries estimated that in the first year, we saved $1,800 per fee-for-service beneficiary that was enrolled in DPP. A lot of people were really mad about this. They were like, this data is terrible, like, you didn't appropriately control and so forth. But what we did was, and this was sort of my decision along with several others, this is part of what I want to get at is, it's not just the data, but it's how you use it. So we went ahead and said, look, this is still, yep, we get that it's not perfect data, but it seems to sort of confirm our thought that the DPP is a good idea. Healthcare moves so slowly, we're going to go ahead and try to generalize this. And actually what happened was the CMS actuary came back and said, sorry, you can't, because yep, it's good for quality of care, it's good for total cost of care, but the problem is people live longer, and if you live longer, you cost more. And so we're not going to certify it. That's actually kind of a problem. Like if you have a life-saving therapy and they say that as a result, we can't certify stuff because you live longer. So well, the point I'm making is that the data can only take you so far. There was a committed group of a small number of us, like 2 or 3 of us, that said that's sort of unacceptable. So we actually went and we just changed the rules of the game in 2016. Patrick Conway and I wrote these 2 paragraphs and got the general counsel in a fit of good mood to just sign off on it, saying that if you actually live longer, we're going to just zero out those costs. So my point is that, yes, the methodology is so important. It's critical to have things that are randomized, but at the same time, you're still playing by a set of guidelines and rules that have been fixed that actually in many ways may not be the most constructive. And sometimes those rules themselves have to be changed. I know Mark, who I just met, has been at OMB and sounds like CBO and a couple other places. This is sort of what we did. And the Trump administration actually reaffirmed this guidance or this way of thinking. So I just put this out there as an interesting example of how the data is there, but what the key lacking quality here is political will and people that are inside the tent that will actually make things happen. And I'll close with this last example. And this is work that was done when I was Chief Medical Officer at Optum and United Healthcare. We were very interested in the opioid crisis. We, again, here, this was non-randomized, but we created a cohort of 50,000 individuals with opioid use disorder. Jeff Brenner, who was just on a little while ago, at the time was in the Medicaid program. This is while I was the Chief Medical Officer of United Healthcare's National Medicare program. We did this study in collaboration with Sarah Wakeman at MGH and Mark LaRochelle at BMC, looked at 50,000 individuals with opioid use disorder, looking at the impact of therapy. Here, again, this is non-randomized. However, this is extremely powerful data that showed that inpatient detox was actually worse than doing nothing, and nothing compared to how great buprenorphine and methadone were in preventing hospitalization and ER use in individuals with medication use, opioid use disorder. Based on this, Jeff and I and a number of others advocated very strongly to remove all prior authorization and a number of other policies at United. That actually, interestingly, also happened in a randomized fashion because some state regulatory boards, they do and don't give us the ability to waive prior authorization right away. This is another incredibly rich natural experiment that we're learning from right now. So I just put this out there to say that, again, it's important to study, but it's also important to act when we have that information. Sometimes it's not so clear, both in the business and in the government world, whether we'll have the chance to wait for that data. So I'm just putting that out there as a little bit of context for the broader discussion. Thanks so much, and happy to chat a little more during the question period.
Thanks, Darshak. That was really comprehensive. Mark, I'm going to hand things over to you.
Okay, so a couple things. I'll just start off by orienting people to my background. I mean, there was some mention of this. I started out at the Urban Institute a long time ago. There have been some mention. I went through CBL, I went through OMB. I was at MedPAC for 15 years and then came to Arnold Ventures the last 3 years. Arnold Ventures is a philanthropy. We look at, complex social problems. There's areas that I know nothing about: criminal justice, education, gun violence, things that I wouldn't know even how to speak about. My own portfolio is focused on reducing the cost of healthcare. And some of the motivation there is the concern that there's a lot of philanthropic attention to healthcare, but it often isn't about restraining costs. That's a little more unpleasant conversation to have. It means some people need to get less money, and nobody likes that. And so there was a sense here of maybe going directly at that issue. And when I say lower healthcare costs, I mean to the three payers who ultimately pay for everything: the taxpayer, the employer, and then the family, and the family really being the final payer of everything. My portfolio is kind of divided into some things that are focused on price and some things that are focused on utilization. We look at drug prices. We have a lot of work in that area, everything from patent reform to price regulation. We're looking at commercial sector consolidation and the prices that occur there in the hospital and increasingly in the physician sector. We're looking at moving more to utilization, the use of the occurrence of low value care, how it can be identified, and then what kind of payment systems would seek to curb unnecessary or even harmful care. And that, I think, begins to get more into some of the conversations that Neil and Darshak were having. We also have some work going on Medicare solvency. That issue is starting to rise again for those of you who track that. And then we have a complex care portfolio, and think of that as focused on the 12 million dually eligible for Medicare and Medicaid, very complex population, 5% of your people, 35% of your spend, that type of problem. We pursue policy at both the federal and the state level. And we fund, the way I think about what we do is we fund a lot of research in order to assemble evidence and to help define the problem. We're very interested in RCTs, but we obviously, will fund descriptive analysis, regression, discontinuity, difference in difference. It just has to be credible, and that the methodology has to meet the size of the problem or the definition of the problem that's trying to be asked and answered. We develop policy. My own staff and myself do a fair amount of this. We work with the grantees to do it as well. But just to be clear, in looking at anything that comes to us, there is very hard emphasis on what is the policy action that comes out of this. There is an interest in building evidence for evidence sake and building the discipline, but very much it's going to be motivated if there's a clear policy angle to it. Ourselves, the staff here and the grantees engage in a fair amount of technical assistance. And then there's also a communications function of disseminating information and also trying to condition the environment for policy change. Like I said, I think we worked very closely with the grantees in trying to spec out the research to make sure that it, has the credibility to answer the question that's being posed, but also to work with the grantee after the fact to disseminate and get some exposure for it, and also to get them in front of policymakers. There's something like 3 drug hearings, 2 this week, and then 1 coming up in the next couple of weeks. And I think something like half of the people testifying have, either done work for us or are currently doing work for us. And I do spend time with the grantees sort of thinking about how they can get their message out and get in front of policymakers. I know I've done that with Neil and Amy very directly. And it's something that we try and pay attention to. I'm not going to have, except to say a couple other things, so I won't get into this. It's unless as a panel and as a conference you want to get into it. I think there are decidedly some key questions around CMMI and its mission and where it focuses. And some of these things have been triggered by both sets of comments so far. Things like whether models should be mandatory or whether they should be voluntary. I agree with Neil. It was a huge step forward when there was a mandatory, or in your terms, an RCT kind of framework where people could really study the effects. And then that was kind of undone. And while I think Neil and his crew made, use of that change, I think there's a question about what is the proper way to think about designing these and whether voluntary models have the same value as a mandatory model. I think there's questions at like what level is risk taking the best level to take? Is it a population risk or is it a risk around, say, an episode of care, such as the joint replacement? I also think there's a very frustrating thing and that goes on regularly where we design things, we actually have savings, and then we give the savings away, both through bonuses and even in our general payment systems in Medicare, like in the MA, where for years and years we have paid more to the managed care plans than we have to fee for service. And I think that's an issue that people should be aware of. I'm going to stop here. The only other thing I'll say is if there's any discussion about sort of how to think about positioning research after it's done, happy to give some thought to that. But that's 7 minutes and I'll stop.
Thank you so much, all three of you, for sharing those remarks. There's a lot we could unpack here, and classically, of course, we have limited time. I'm going to try and weave together a few things here. So we did just receive a question from the audience, which, Mark, I think sort of ties nicely into sort of one of your last kind of rhetorical questions that you finished your remarks with. So, the question really here is sort of about, I think this is really to everyone. The question in particular that I'm reading, was sort of targeted toward Darshak, just given sort of your role inside, previously inside CMMI. And the question really is, what are your thoughts on, how researchers can or should move the needle on stakeholder opinions, right? So we do all this research. I think all of us here are really interested in ensuring that that research is used, that it's helpful in decision making, and that people are interested in sort of using it in ways that are meaningful. And so the question really here is, what should a JPAL or a researcher's role kind of be in moving the needle on that? Should there be a focus on that? Does it have to come internally? Maybe Darshak, maybe you can begin, since I think you sort of mentioned some of this in your remarks, and then Neil or Mark, I think you should feel welcome to jump in.
Sure. I mean, yeah, it's interesting because I think that there's a particular case in health policy where there seems to be a gap between those who are engaged in a lot of health policy research and the receptors on the other side. The thing I'm always sort of struck by is like that it doesn't have to be that way. I'd say a couple things that are systemic, or part of it is even the personality of those that are introduced. So I think that by necessity, researchers are often very circumspect. Like half the time I can't understand, like after the presentation is done, like what they really believe, what they think I think it's okay to sort of develop a speaking style which is a little bit clearer and often more directive as well. And this is a problem in all of academia, but it's particularly acute in health policy, which nobody can understand anyway. So I'll stay with that as part of it is on academics to communicate more effectively. The second piece is there's a broader set of incentives, which is that for whatever reason, the experience in government, academia, government is not valued by academia. You're given 2 years to come back. Who knows what's going on with your tenure clock? And even if you're running very, very large programs in the federal government, for some reason that's not recognized in academia. And so I think there's this kind of challenge of, well, is it really worth that time to engage in a meaningful way? Might be something that I'd really look to leadership to think about. Well, how do we address that? I mean, there's a bunch of other approaches as well. And the last thing I'll say is perhaps one other medium-term approach is that engagement and impact is something that can be created as well, principally by engagement with non-academic publications. And by that, I mean like New York Times and so forth and well-trafficked blogs, but it does take effort to do those things.
Yeah, I would decidedly reinforce some of that, and no disagreement. I'm just trying to figure out where to start, because this is an incredibly frustrating. I've been at this probably longer than a lot of people on this thing, and I'm asked on a daily basis why I keep doing it, given the level of frustration, and it's just a mental health issue at this point. And so there is, first of all, there's distinguishing between what is a legitimate concern on the part of a stakeholder and a recognition that there are people routinely paid just to maintain the status quo. And they are extremely powerful. They have a lot of money, and it is their role to make sure that things don't change, because as things are working in their benefit at the moment. What I think a researcher's role is remember, that evidence derives from the research community, and evidence and facts are the best way to push back on arguments that don't have a lot of standing. Now, to burst the bubble of anybody young on this thing, evidence isn't enough. If you have political power and you have money, you can still, defeat evidence any day of the week, but you have to have that at least to go back. And so the research community can be very valuable in at least feeding the evidence, and also acting as someone who speaks it directly. So if an academic testifies and something is erroneously said, and they can come right back in testimony, that is an important contribution, because they are generally viewed as neutral and just trying to drive at the truth. The other things I would say, and I think Darshik said some of these, and so I want to reinforce these. Your message has to get simplified. If you want to have an impact, it has to be simple and repetitious. And I'm sorry to say this, but tons of academics need to caveat it and say too many words, and then give the also, and that message can really dilute the impact when that happens. Simple, repetition. I also agree with his point of exposure outside of the academic journals. And this is some of what I was talking about, is trying to help people get into, The Hill, Roll Call, the Stat, whatever, even the rags. It's very helpful to have mention for the research results, because it's what people say on the Hill or in a state legislature would be reading, and that can get exposure. And then the last thing I would say is some flexibility on the policy. So Neil and Amy did some really interesting research on long-term care hospitals. They had a conclusion which I completely agreed with. It was a very hard political conclusion to get to. And in conversations with the Hill, when we were all together, and people were saying, well, this is complicated, I could give them 2 or 3 alternatives that they could use the same evidence to push at least in a better direction if they couldn't take the whole ball of wax. So think about things, from a flexibility point of view. I'm sorry that was so long-winded, but that kind of hit close. So.
No, it's a big topic to try and cover in a matter of a few minutes. We have essentially come to the end of this particular panel, but Neil, I want to give you the opportunity as the researcher of this trio to sort of share any thoughts that you might have. I know Mark just mentioned your experience, with the long-term care hospital work, or any sort of last insights you might like to close us out on today.
Yeah, I guess one thing I'll say from the researcher perspective is, I think you never want to have your heart set on having a political impact, because our research takes a while to produce, and the political environment can change pretty quickly. So it's good to have a policy impact motivation, but that can't be the only goal. I think the flip side of that coin is, if there is an opportunity to rush at it sort of with all your enthusiasm, and it might be for an old paper. You might have written a paper 4 years ago, it's not even on your radar, and suddenly the opportunity is right. And if you see that, right, to sort of grab the bull by the horns. So I think that's you sort of have to manage your own expectations if you're going to be a researcher with these broader objectives.
Thanks, Neil, for your final thoughts. I want to thank all of you for joining us this afternoon. I know it's busy these days, so we appreciate you taking the time and talking with us. One plug I will shamelessly make for JPAL, speaking of sort of policy influence and ensuring that that research is out in a place where it's accessible to policymakers and decision makers. That is a big part of our mission, and the JPAL North America team, HCDI team included, really works hard with PIs to ensure that their work is out in the public space so that policymakers have access to that information in plain English. So we look forward to supporting Neil and the other PIs on the CJR work and disseminating that work, and of course learning from Darshik Sanghavi, who we've recently appointed to our HCDI advisory committee, and Mark in his relationship with us at Arnold Ventures. So thank you all for sharing your wisdom and your insights.